All right, Neil. How you doing today, man?
I'm doing pretty good.
Good. Good to see you.
Good to see you.
Hey, I'm excited about this conversation today. We're going to talk about CDI.
Okay.
And so I know you've given tons of presentations on it. We've been talking about it for, a couple of years now, I think. And so let's put some bones to this and give some definitions to our viewers here and talk about CDI today.
Let's do it.
Let's start with a definition. So give me a definition of CDI. What is it?
CDI is it's really when the bony structures can no longer protect the neural elements. And I like that definition. It describes chronic pain. It describes a lot of the patients that have pain from an aging process. Their segments are just kind of breaking down and getting older. But then also, it helps us to kind of focus in on the patients that don't have what we traditionally called instability, which is the gross instability. These are more simple instabilities, and there's a lot of patients kind of trapped in this zone that we need to focus on.
I love the term simple instabilities. That is so helpful. So let's jump into the 3 stages of CDI. What are those?
The 3 stages of CDI, as defined by the publication by Yonghing and Kirkaldy-Willis, the publication in 1983, is dysfunction, destabilization, and restabilization.
So let's start with dysfunction. Who is that patient? What are some of the findings and imaging there?
Mm-hmm.
Dysfunction.
Dysfunction, that patient I think is probably best described as it's the first stage, it's the slowdown, right? It's maybe where the family starts to notice that maybe a parent or a grandparent is not doing the things that they used to do. Me personally, in my family, I think that my grandpa and my grandma, they soldiered through a lot of pain, but the big time, I think the thing that our family felt the most was when my grandpa was like, I'm not getting on a plane anymore. I can't go through the airport, that kind of thing. Mm-hmm. The slowdown.
All right, then stage 2, destabilization.
Okay, so destabilization, I think, in layman's terms, I describe that as a laxity, like segmental laxity there. What you will see is kind of a carryover from the dysfunction stage 1, of maybe increased vertical instability or loss of disc height. You also might see some various degrees of stenosis in this as well. But it's more about the segment being lax or loose, if you will. There could be some translation instability there. It could be some micro instability showing up in the shear force that's happening on the facets. And a patient could be complaining of back and or leg pain as well. But that would be your second stage as you kind of progress there.
All right, and then stage 3, restabilization. Let's talk about that.
Restabilization, that is I think a stage that's kind of near and dear to our all Team Minuteman here, because these patients are maybe up there in the aging process, and some of them are pretty upper Medicare age patients here. And what's happening there is, yes, there is loss of disc height that was present in stage 1 and stage 2. Yes, there may be some stenosis. There may be some compromise of the neuroforamen, causing some leg pain, those things. But around all of this, the segment is kind of settling and restabilizing itself in a painful position. This is a stage of stiffness or rigidity. And the Minuteman can actually help with that as well. When I think about the stages here, maybe stage 1 is too early for Minuteman. Many of those patients Americans are strong, they're soldiering through, right? But stage 2 and stage 3, when I think about those, I think about what do we want Minuteman to accomplish and what are they capable of doing. The Minuteman device itself can lift, balance, realign, and secure a segment. And so I think that really endears you to where these patients are on the chronic degenerative instability stages.
Okay, that's super helpful. So now we can look at some of the hallmarks of CDI. So vertical instability, angular instability, micromotion, static spondy, and and translation.
You got
Those
it.
are our five hallmarks,
Yeah,
right?
it is.
Okay,
That was well said.
let's
Yes.
dive into those. So,
Vertical-
VI.
VI.
Yeah.
Yep. VI, vertical instability first. We talk about that as this loss of disc height. That's probably the best thing to point out there. We think about our grandma used to be like 5'2", now she's 4'11", 3/4. That is where that is. Think about that segment being a little bit shorter and the disc drying out. So when we think about what we want Minuteman to do out of those four things, lift, balance, realign, secure, this is our lifting process to combat vertical instability. Second was angular instability.
Alligator mouth, right?
Alligator mouth, yep.
That's my layman's term.
Yeah, that's great. That's super helpful for me. We were actually explaining that to the kids. Like, this is what we look at the imaging, right? The alligator mouth is a call out for indirect decompression. These are patients that have neurogenic intermittent claudication, that classic shopping cart syndrome. They get relief in flexion, pain and extension, and it shows up like that alligator mouth on the Flex X. So the call out about Minuteman's capabilities to correct angular instability is the balance. Right now we're lifting the vertical instability and balancing the angular instability.
Love that.
Yeah.
And then there might be some micromotion in that segment as well. So
Yeah.
instability, micromotion instability. Let's talk about that.
So micromotion instability typically will present itself in stage 2 CDI, where that is the laxity stage, right? There's that laxity's got to show up somewhere, and a lot of times it'll show up in the facets. Your MRI will show you maybe some fluid in the facets as those facets are building up to kind of restabilize that segment eventually. That's a sign and an indication of micromotion instability. The patient might have some back pain there, but that's the kind of the third, one of the four call outs of what Minuteman can do. Now we're lifting, now we're balancing, and we are securing the micro instabilities there.
Okay, now moving on to stage 4, hallmark of CDI, spondylolisthesis, static spondy. So let's talk about that patient.
So static spondy was, it is a misalignment instability, right? That's what it needs to be respected as. It had to move to get there, and it may not be moving any longer because the patient is in stage 3 CDI, which is the restabilization stage. So now the patient is stuck with this misalignment instability. And I say that they're stuck for a couple of reasons. Their segment is stuck, but also they may be actually stuck in some miseducation or misinterpretation of what's happening. I've actually seen some paperwork with the doctors. They say, oh, it's a stable spondy. And I think I know what they mean, that it's no longer moving, but that's not stable because our definition, when the bony structures can no longer protect the neural elements, patient has pain because of that misalignment instability. So that's really where that is. It could produce leg or back pain, but any time that we see on the MRI or Flex X that you have a shift of one segment over the other, that qualifies. And the Minuteman, we did talk about how it lifts, balances, and secures. This is where we can realign some segments into a healthier alignment.
Super helpful.
Yeah.
And then I think historically, commonly, instability, when our doctors think about that, they think about this 5th stage, which is translation.
Sure.
So talk about translation.
So translation, I think is, first off, I'd like to say for the purposes of Minuteman, we want to talk about minimal translation, particularly if you're using it standalone. Obviously it could be part of some of the more complex cases. So we appreciate those surgeons that do a complex spine as well. But for minimal translation, I bring us back to stage 2 CDI, laxity, right? And so there, those patients, we talked about this morning, right? They had this transitional pain complaint where it's like maybe loading the dishwasher, getting in and out of the car, getting in and out of bed is really what's bothering them. Could be leg pain, could be back pain, and this is going to really show up in your flexion extension x-ray where it's shifting over each other. And again, those patients, you think about what Minuteman provides: lift, balance, realign, or secure. Those patients need their segment secured.
No doubt. Okay, so it's helpful to think about the 3 stages, the 5 hallmarks. We talked about the imaging, how the patient is clinically feeling in that moment. So let's go back to the Punjabi and White paper, 2003. They give us some guardrails on how to prescribe, how to diagnose this. So we've got the 5 columns of instability. So talk to me about those, the point system that we have from Punjabi and White.
This is a publication by White and Punjabi in 2003. So it's been around for a while, where it's talking about clinical instability. That first column is you can get a total of 2 points by just checking one box. And that first column is talking about the dysfunction that's happening in the anterior column. Fair? And that's as easy as getting the imaging and seeing something like loss of disc height, or maybe even modic changes or something like that in the anterior column. Then the second column would be kind of dysfunction or damage of the posterior column, with a total of 2 points that can be achieved there. And you only need to get 5 points to be deemed clinically unstable. And so that second column, it's like facet hypertrophy, canal stenosis, lateral recess stenosis, nerve foraminal stenosis. Very easy to get 2 points in those first 2 columns, to totaling up to 4 points. Now the third column is what I really love, where you talked about translation, even the alligator mouth. This is the flexion extension radiograph column. And it really tells you a lot of information there. There's 2 boxes that you can check. If it's translating, check the box. And then you get a total of 6 points. 6 is greater than 5, last time I checked, right? And so that you can really help that patient understand that they are clinically deemed unstable at a segment. However, we talked about stage 3 CDI being that restabilization stage. So not all these patients are going to be translating that way. There are going to be many patients that have angular instability, and your flexion extension radiograph is going to be able to point that out. So in that column there, in this publication, at 4-5, all you need is 20 degrees and change from flexion to extension to be deemed unstable at 4-5. Now 3-4, 2-3, 1-2, all you need is 15 degrees change there with the symptoms that match to that, and you can call out a segment as unstable.
Yeah, I love that the research helps us get to that point. So we're talking about the stages, the hallmarks, but the research really guides our thinking and making sure we're diagnosing properly there. That's really good.
And the research has been there. What we didn't have was a product like this that we trust, like a Minuteman, to do all those things of lifting, balancing, realigning, and securing, while preserving so much anatomy. And sparing the supraspinous ligament and the multifidus, and getting the patient up on their feet same day, those kind of things.
Yeah, that lateral approach is amazing for that posterior column preservation there.
Absolutely.
Okay, so I think it's also important we talk a little bit about guardrails on. So we've talked today about who is a great Minuteman patient, but who is not a good Minuteman patient, Neil? Who would not do well with Minuteman?
I think that's awesome. That's a great question, and something that Spinal Simplicity needs to be responsible with, as do all companies, right? We talked about the call-outs. What's a great patient? I think a great patient for us would be just predictable outcomes, predictable success, right? And so if a patient, we can predict success by following our studies that we have and those guidelines for patient selection, but also really paying attention to, does a patient get relief in flexion? Or what position of comfort does the patient get in? Because you can model your Minuteman capture for that, and really promise no more than what the patient is able to naturally do for themselves. Now, patients that don't get relief in any position, that's not going to be a great Minuteman candidate, and there's nothing to predict there. And so we don't want to implant anything on hope like that. The other patient I would say is a patient that had, maybe pretty obvious, but a patient that's had a laminectomy, and we can't safely place the implant. A patient that has severe osteoporosis might not be, that is contraindicated as well. Gross instability. If it's translating, greater than 5 millimeters, then you should have a cautionary finding of getting a CT, making sure there's not a pars fracture. But also, if it's translating around that 5 millimeters or more, you probably won't have a patient that clinically tells you that I get relief in flexion. So that's going to be a patient that you want to refer out to more of a complex solution.
Super helpful, Neil.
Yeah.
Bony structures no longer protecting the neural elements.
That's what we do.
Great definition.
Yeah.
Thanks for talking about CDI today. That was fun.
Yeah.
Very informative.